talk.
I talk.
Welcome to today's iTalk. Today's guest is Dr. Rohit Om Parkash. He is an accomplished cataract and refractive surgeon. He has many national and international publications. He has described flap motility sign, posterior capsule, flutter sign, and many other innovative techniques for betterment of cataract surgeries. He runs instruction courses in national and international conferences. He is a judge of the prestigious event of Film Festival in American Society of Cataract and Refractive Surgeon. Thank you, Dr. Rohit Om Parkash, for coming to iTalk. And you are a very busy man, busy surgeon, but despite that, you have agreed to come and share your ideas, thoughts, and knowledge with the ophthalmologist of Bangladesh. So today we are going to talk on capsule integrity and the importance of it when we are doing cataract surgery, be it anterior capsule or posterior capsule. So we know the immense importance of integrity of the capsule and capsulorhexis, because nowadays with all the premium lenses, we have to put in the back effective lens position. Of these things come into play.
Absolutely. You're absolutely right, because integrity of capsular axis with its perfect size and centering make the most important prerequisites for effective lens position and long-term effective positioning of the intraocular lens.
So Dr. Rohit, I'm going to share one of my videos. So this is the video that I did many years back. So this was a white cataract, and I just nicked it, but what I did wrong was I tried to increase it,
Yes,
and
absolutely.
it just kept going. I gave high OVD and
Yeah,
this sort of things. So
a very
this was
difficult, a very difficult position for the surgeon, because you just happen to start, and it ripples out and creates an Argentinian flag sign. Well, this Argentinian flag sign, this is something which really is something which all of us make efforts to really prevent this Argentinian flag sign. And there are a few things which when you would have looked back, you would have realized a few things altered. When you retrospect, you would have felt that it could have been avoided. I think if we have to go into the detailing, in this patient, we obviously needed to have a very strong visco-cohesive in the anterior chamber, so that the anterior capsule would have flattened out. Because we have to realize that in this patient, wherein you just nicked and it went out, I think the intralenticular pressure was very high. It was high both in the anterior compartment, which is anterior to the nucleus, and the posterior compartment as well. So this was the situation wherein, going in and creating an opening with slightly larger, incision size, also creates a position wherein the OVD, aggresses out of the incision, and the pressure in the anterior chamber decreases, and it causes the radialization of the tear. So, yeah, some people use intravenous mannitol also, to preoperatively, so that the volume of the vitreous also decreases, which reduces the intralenticular, uh, volume and the pressure inside the eye.
so for this sort of patients, do you suggest to give peribulbar anesthesia or topical? Does it make any difference for you? Or
Yeah,
young surgeons, what is your advice for them?
absolutely correct. It should be given, and if you can add hylays also, that also helps, because that will help to peribulbar, and that will help to spread out the spread it out so that the pressure also decreases. So peribulbar definitely, if one wants to, can definitely be used.
So this is another situation where it did not run at first, we did a small one. And so this is one of the surgeries that you had sent. Can you just, so what do you think went wrong here, and how it could have been prevented? I'll
You
just
know,
play it one more time. So
yeah,
actually, yeah. So two-third went very well, but when
yeah.
it was nearly at the end of the recapsular axis, it just went to the periphery.
I think there were three mistakes in this. First of all, the first thing was that if you see the center there is some concavity in only a minimal part, which showed that right in the center, the intralenticular pressure was low. The first mistake which I did was in this patient was that I took the flap while creating a rhexis into the area which had high intralenticular pressure. So that was the first mistake. And not to forget the same mistake which was there in the video which you showed previously. In this also, the OVD which was used was not a high viscosity OVD. It was just HPMC in this patient. And third, if you find, while I'm trying to create a rhexis flap, there's a mismatch between the incision size and the forceps which I'm using. So which was causing the OVD to egress out, and ultimately it created a situation in which the flap went out of control and there was a rhexis there. Anything else you would like to add, Dr.
Yeah, I
Ishtiaq?
think so. You have mentioned very two important things. One is OVD, so, that we should use high viscous OVD, and incision size.
Yeah,
I know that you are very particular about the incision size. You also prefer making a very small and calibered side port also. This
yeah,
shows that
absolutely.
how much the importance of incision. So what you are suggesting, that rather going through the main incision, we can go through the side ports while we are doing rexis in this sort of situation.
Absolutely, absolutely.
Do you think that, if we are going through a side port, rexis size is small, rather than this conventional capsular rexis forceps, we can use micro
Micro,
forceps?
absolutely,
Will that
absolutely.
help?
100%. There's no second thought. And another thing which I would have done, which I do nowadays, is that I create once I have decompressed in the
Yeah,
center.
so I'll just run that video. So
Yeah,
this is the ideal thing that you want to show us.
yeah,
So if you just
yeah,
narrate what,
yeah. So I'm going through with a 30 gauge needle. So can you pause it? So with this 30 gauge needle or the 26 gauge needle, I decide. Because if I find that it is highly liquefied, then I use a 30 gauge needle. But if I find that it may be slightly thicker, in these patients, I go in with a 26 gauge needle. And now what I'm going is the moment I enter, simultaneous, can you pause it? Simultaneously, what I do is I start aspirating the intralenticular fluid. Now this intralenticular fluid, which when it has to be aspirated, you would have seen that I have put it at as beveled down, because I feel when at times I used to place it at bevel up, there never used to be that much of aspiration of the highly liquefied intralenticular cortex. So next is, I'm not remaining in the center. I'm moving left, right, more towards the opposite side and towards my side, so that I have a small area right in the center which becomes totally concave. As you would see now, once that has been done, the next step is I create a small rhexis, and that is right in that, can you pause it, right in that area. So what I do is I make it right in the center where there is concavity. Now this concave central area is now a very safe area. Now the area which needs, now two things need to be taken care of. The first is the intralenticular pressure, which is periphery to the central small mini rexes which I have created. And the second is the posterior compartment, which is posterior to the central nucleus, that has to be taken care of. Now, for this, I use two maneuvers, which one of them is the one which Chi has taught us, that I'm milking it. Milking it, I'm the pushing the high intralenticular, cortex from the periphery to the center. And I gave a nudge also, if you saw. So that nudge which I gave was the one which, created a situation where the posterior cortex from the posterior compartment was brought forward. Once that was done, you will see now how easily I was able to complete the rexes.
So that was a spatula, or you use a
You can
syringe to as aspirate also while you are doing that?
you can use a spatula also, but what I do is I use the cannula which I have with me, a 26 or 27 gauge cannula or 25 gauge cannula. So with that, I just milk it towards the center, so that the intralenticular fluid, which is in the periphery, which is highly pressurized, that gets taken care of by its movement from the periphery to the center. Next, what I did was, if you saw it, I just pushed the nucleus. When I pushed the nucleus, that created, a place in the equator from where the posterior cortex in the posterior compartment that came in front, thereby decreasing the predisposition for the, capsule rexes which I created, so that rexes didn't move to the periphery.
Very nice tips. But once what I had in one surgery, I did a very small rexis, and I thought that once we do a small rexis, nothing is going to happen. So I was maybe little rough with my handling while I was milking it,
The
and
way
when I
the way
it
she
just
has,
split.
yeah,
It just
yeah,
split. So
it splits. It has not to be very small, because when it is very small, and if you hit the capsule rex's, the mini capsule rex's edge, and when you
mhm,
go, I also had this problem once. So it is not, because problems happen with everybody, and there's always a reason. I think if you make it the way I made it, slightly larger,
mhm.
that creates a situation wherein there is less stress to the capsule rex's edges, and that doesn't give way and give a capsule rexus tear which goes right up to the periphery.
So two tips I would say: that not too small, and also after making a small rexis, we have to be gentle with it. It's
Yeah,
not like that
absolutely.
it cannot again split.
Yeah, absolutely correct.
Okay. So now I'm going to show another video. So do you do this? There are some good literatures that suggest that you do a yak cap before the you take the patient. Any experience or your thought on this?
I think this is a very good innovation. Dr. Trupti Sharma, who is with us, who is in our other branch, she does it very often. And she does it around 30 minutes before. And she has found that the intralenticular pressure, with the YAG laser, she creates a spot on the interior capsule, which creates a cruciate sort of incision. And you wait, and you will find the way you showed the milky fluid coming out. And by the time you go into the into the OT and start doing the surgery, you will find that the pressure has almost become a normal pressure. So it's a very innovative, very effective, which doesn't require anything, which makes the surgery very easy.
So after you have done a yak, do you go for again a small rexis, or you can just go along with a 5 mm
I
rexis?
think you can, to be on the safer side, you can initially make a small one, but you will realize that how the control which you have, at times there's no problem at all. But to because at times we want to situation create a situation in which we do not have a rexis there, in that you can make a smaller one also without any hassle. But if you find that the going is good, there's almost lots and lots of fluid which has intralenticular fluid which has come out, then you can make a rhexis, which can be a large one depending upon the situation.
So Rohit, in 2017, I think you described the flap motility sign. I
Yeah.
think it's a very innovative thing. It shows that how keen you are observing your surgery's every point.
This is a graphical animation in which if the anterior capsular tear, when you have an anterior capsular tear, if the flaps are everted and fluttering, this shows that the anterior capsular tear is pre-equatorial. If by any means, can you just pause it? If by any means it stops fluttering and becomes inverted, this shows that it has become a wraparound tear. Now, there's a physics behind it. And this physics behind it is that this, the if it is a pre-equatorial tear, the end of the tear that acts as a fulcrum, and it becomes responsive to the fluidics in the anterior chamber, and it starts to flutter. So that end becomes responsive to the fluidics in the anterior chamber, and there's a fluttering and everted flap. And if by any means it becomes a wraparound tear, then the flap, the fulcrum has gone behind, or around which it has to rotate. So, it has to move. Since it is not able to move, it creates a situation that it becomes flat, inverted, and non-fluttering.
So, Dr. Rohit, after how many surgeries did you locate this thing, or it was during the surgery, or you saw your videos and found this? Uh,
You know, it's a if you ask me, it is never one man's job. So basically, with me, I was also looking into it, and I would like to state that there's the second editor who was with me in the paper which we published is Dr. Vinod Byala. So Dr. Vinod Byala, who is based in Delhi, we used to work together way back after our post graduation. He suggested, and we all went and looked into it, and it was just a combination of his and mine interactions and looking into the videos which led us to the flap motility sign.
so this is a great sign, that helps us uh, after a split. We can decide that whether to approach, how to approach.
Yeah,
So, if
but then you have to realize that there are false positive also in flap motility sign. So if by any means there is a pre-existing tear, such as in those patients who have had an intravitreal injection.
Mhm.
So there, if you have an anterior capsular tear, but there's already a pre-existing one, so in that case, it will give a false positive one. And second is all four flaps or two flaps, if it is an anterior capsular tear, and if it is an Argentinian flag sign, all four flaps have to be everted and fluttering. Because if at one side it is fluttering, the other side it is not fluttering, then also there can be, you can have a false positive feeling that it is a pre-equatorial tear.
So we will see a surgery of yours that split,
Yeah,
and then how you observed and did that. But
yeah.
just to emphasize one point, that if there is a split, what are the first things that you want to you know teach your residents or the learning surgeons? The one thing that
First,
we must do first thing, because our first response is that we come out immediately.
yeah. So the first and foremost is no panic mode. Do not panic. Gather yourself. Do not let the chamber collapse. If it has happened just after the rhexis, the first thing which you should do is just see what I've done. I've just injected visco. And the moment I inject visco, you will find that the flap, did you see that it became everted? This shows that the flap is prequatorial. This is the second evaluation. Go in, fluid on, irrigation on, flap fluttering, This shows it is prequatorial. Can you pause it here for a second?
Yes.
So now I would like you to see the fluidics which I'm using. I'm hardly using an IOP of 20 and with low flow rate. That is the basic concept with which we have to move. The third thing which we have to realize is just see the incision. The incision is not in line with the tear. That is a very important factor which we have to bear in mind. Because if at times it is in line, that can also predispose it to a post equatorial tear. Then another important thing is that while sculpting, I am not pushing the nucleus. Pause it, look at the separational forces. Can you pause it? The separational forces are in the direction of the tear. So separational forces should also be in the direction of the tear. Another important thing, you should not rotate the nucleus. Now, the next question which should come in your mind is that why did I rotate the nucleus? I rotated the nucleus in this patient because of one simple thing, because it was a mature cataract and there were no strong capsulocortical adhesions. Since those were not there, so it was almost stress free. And another important thing which I was doing is with this safe phacoemulsification technique, I was emulsifying interiorly. And if you pause it and had you seen it, I was constantly having a vigil on the anterior capsular tear flaps. They were always everted and fluttering. So that showed that the tear was prequatorial. It was reassuring that with all the techniques you can continue. Another important thing, you should always have stable chamber settings. So while bringing out the phaco handpiece, you see the way how I am injecting so that there is stable chamber settings. Now I am enlarging the rexes, but there's one mistake which is there. And what is that mistake? The alignment of the IOL should have been at 90 degree to the anterior capsular tear flaps. So these are what the tips are.
So you continued with your stop and chop lateral separation. If somebody is habituated with divide and conquer, what would you suggest they would do that?
Yeah, they can do that, but then if you can do cross chopping so that you bring it out, so that can be done. But definitely, if you have to do divide and conquer, then obviously your rotation has to be minimal. And if you can, take out one nuclear fragment by just doing cross chopping, that will create space, that will not put pressure, and then you can continue. Because if the bag is full and you are trying to rotate with strong capsulocortical adhesions, in that situation, it can predispose to the tear becoming a wraparound tear. Low fluidics are also very important because when you are using low fluidics, you are not putting stress at the end of the tear flap. When you are not putting stress, you are not creating a situation that it becomes a wraparound tear. We have to realize that anterior capsular tear doesn't usually become a wraparound tear unless and until you really insult it, because the what should I say, the capsule is thick in the anterior capsule is thick in the mid periphery slightly, and the zonule attachment that doesn't allow the anterior capsular tear to suddenly become a wraparound tear. So if you are meticulous, you can continue, but mark my words, you should definitely not push yourself, because at the end of the day, you want to give a surgical outcome which has to be up to the visual requirements of the patient. If you are not sure, it's always better to convert than to create a situation where you are not comfortable with.
What about supracapsular phaco? In this sort of
So,
situation, there is a split.
yeah,
Should
absolutely.
anyone bring it in the anterior chamber and do it?
Absolutely right. If you remember, you when I was trying to chop, I was
Mhm.
bringing the nuclear fragment into the supracapsular area, and I was using I don't know whether you saw or not. I was using chopper as a shield. So
Yes.
this we published. We placed the chopper anterior to the nuclear fragment, and that prevented the nucleus from coming and hitting, rebounding and hitting the corneal endothelium. So that can also be done.
Yeah. So if there is a split, you can bring it in the anterior chamber. The cornea is going to be little hazy. To prevent that, you're putting a
Yeah.
chopper as a shield.
So supracapsular phaco, as you said, I absolutely agree that should be the choice, and I did it in that case as well.
So now coming to the posterior capsule, we have been talking about the anterior capsule split if there is a rexis split, but the posterior capsule is, I think, more or important than the anterior capsule, because if there is a loss of integrity in the posterior capsule, then giving an IOL in the back where we have to place, how to proceed the surgery, this is more challenging in some cases. We can see that there is a capsular posterior capsule rent,
Yeah,
and so
and yeah,
this is the
yeah,
video that I was if we see what is the surgeon is doing.
yeah. You can see that the posterior capsular tear is there, and when the surgeon wrongly takes it out, there's a vitreous loss. So now this shows that posterior capsular tear and vitreous prolapse, they are two separate identities. All posterior capsular tears do not cause anterior hyaloid face rupture. But we have been taught that posterior capsular rupture, when we are talking of it as a posterior capsule rupture with anterior hyaloid face rupture and vitreous prolapse. So we have to realize that these are two different entities. First of all, posterior capsule rupture occurs, and later on, if you do not give respect to the anterior hyaloid face, the anterior hyaloid face rupture occurs. But if you are using high fluidics, the interval between posterior capsule rupture and anterior hyaloid face rupture, they become one. So, Vasavra et al. Have shown that even with an intact posterior capsule, you can have anterior hyaloid face rupture if you use high bottle height and high flow rate. So, low flow rate and low bottle height creates a situation wherein if there is a posterior capsule rupture, you can at times, if you have not created a trauma to the anterior hyaloid face, you can keep the anterior hyaloid face intact and create a situation where posterior capsule rupture and anterior hyaloid face rupture are two different entities.
So 2 point I would take that first of all, um, don't take the IA probe or Phaco probe if there is a in any situation. Assess the
Absolutely.
situation, give
Absolutely.
OVD, make the chamber stable, then only come out.
Yeah.
And
You
second
know,
thing is that if some surgeons are doing at a higher parameters, to low down the parameters, it's always better to do surgery in a low parameter. But there are such surgeons that are prefer the surgery in a high thing. But if there is a any complication, we should lower all the parameters as soon as possible.
Absolutely, absolutely. That is the first and foremost thing which we have to realize. Because if you continue with the high fluidics, high flow rate, you can create a situation wherein you can rupture the anterior hyaloid vein. Now, if you see in this patient, what is happening is that these anterior capsular tear edges, they are, do you find them static or do you find that they are moving? Well, they are fluttering. The motility of the flaps of the,
Yes,
this shows that
exactly.
the anterior hyaloid phase is intact. So now, in this situation, you go in through the side port with stable chamber settings, and one can easily round off the rexus margin. Because if you have to implant an intraocular lens in the bag with an open posterior capsule, never do it if you have not rounded off the tear edges. So that is one important thing. And the most important thing is, with your knowledge of the posterior capsular tear edges, whether they are fluttering or not, is a real time sign which shows that the anterior hyaloid phase is intact. You definitely need not put triamcinolone on. You know, and I know, and all of us know that there's only God, they say, as Mohan Rajan always says, even God cannot see, vitreous. Only triamcinolone can. So triamcinolone was the only one till that this flutter sign came up. This flutter sign, there's a very, a beautiful history about it. It is Richard Packard who had shown in 2021 that if the posterior capsular tear edges are straight, sharp, this shows that the anterior hyaloid phase is intact. And if by any means they are not straight, they become scalloped, this shows that the posterior anterior hyaloid phase has ruptured and it has become, and there's a vitreous prolapse. So what we did was, we went through our videos retrospectively. We started the study way back in 2021-22 after seeing Richard Packard's observation, and we realized when we put it on slow speed that in addition to it being sharp or straight or whatever you want to call it, there was some mobility in the posterior capsular tear edges. This showed that the anterior hyaloid phase is intact. And if by any means it becomes scalloped and it stops fluttering and it becomes static, this shows that the vitreous has prolapsed. So this is what basically Richard Packard, and we built it on that. And then we had our co-authors like Deepak Magur. He is very much into it. And another co-author of ours, Abhijit Desai from Mumbai, he has also worked on it. So it was a conglomeration of all the ideas, and which has brought forward this flutter sign.
Years of experience of all the surgeons,
Yeah,
helping the uh,
absolutely,
young
absolutely,
ones. But ultimately, what we want is that have a good outcome for the patients. So
absolutely.
one point, Dr. Rohit, that IOL choice, when there is a situation like this, anterior capsule split or posterior capsule rent, what are the options of the IOL choice that you consider putting?
Look, when there is an anterior capsular tear, it's always better that you have an Argentinian flag sign, which you have enlarged and made it into a space with a capsular axis. But then you have to realize, if you put this a premium intraocular lens, there is a long-term chance of the intraocular lens getting decentered because of asymmetric contraction of the capsular tear edges. So when you have to see a long-term plan, then you have to be very clear that these premium intraocular lenses one should try to avoid in a patient who has an anterior capsular tear. And if you have to put a toric intraocular lens, then again you have to realize that it can again get decentered if it is not at 90-degree to the axis of the anterior capsular tear. So you have to be very clear that long term, with an anterior capsular tear, premium IOLs may not be a long term choice in such patients. When it comes to a posterior capsular tear with an anterior hyaloid phase intact, and if you are able to round off the capsulorhexis, the posterior capsule, into a posterior capsulorhexis, and that too not a large one, because ideally it has been seen that if the posterior capsulorhexis size is more than 3.5 or 4, that creates long-term instability. So that should be avoided. No doubt, you can do, what should I say, a posterior capture, or the, reverse
Reverse
optic
capture,
capture.
reverse
Reverse,
optic capture.
yeah. At this age, at times, you forget the reverse optic capture can also be done. But then, if you are doing reverse optic capture, you have to bear in mind that there are three things which are definitely there. The first is the capsulorhexis size has to be small. If it is not small, then you cannot have a long term reverse optic capture. The second and most important thing is you have to do some calibration of the intraocular lens power, because when you're bringing it forward, you have to reduce the power. So that part should definitely be taken care of. Vasavda et al., Shal Vasavda has shown quite a few cases. Dr. Ramamurthy in India, he has also, they are great, and not to forget David Chang. They all talk of reverse optic capture in such patients wherever it is possible.
So that's a very important point you have brought, that we might have committed to some specific lens, premier lens, but for the long term stability we have to shift to other lenses if required. So coming to the last point for today, I would say that years of experience, one important issue is counseling the patient. If there is a split rhexis or whatever the situation is, and we have not been able to give the IOL that we committed to the patient previously, how do you communicate to the patient, and what is the best option? Because at the end of the day, this is one point that I want to hear from you, that making the patient happy even in these sort of situations when things went not as we planned.
The most important thing is transparency, number one. You have to tell the patient what has happened, and you have to put up a very brave front. You have to create a situation where you have to tell that this was the thing which has happened, and it has been managed in the best possible thing, and we have avoided so many things. So never hold back the truth, be confident, and do it in good spirit. The patients always understand.
So thank you, Dr. Rohit Om Prakash, for the time, and you just keep on doing amazing things, come up with this innovative science that will help the surgeons and our patients.
Yeah. Thank you, Dr. Ishtiaq. I have been a great follower of yours and your work in IFIS. I was there as a film festival judge, and we really liked your, for that irrigate when you do hydrodissection, so that there is no sudden efflux of fluid and no iris prolapse. At times, small things make huge difference, and I think your that small, innovative, conception to prevent IFIS, I think it was a creditable innovation of yours.
Thank you. It really means a lot coming out from your mouth. So again, I thank you, and hope this will help our young and experienced surgeons of Bangladesh how to manage a cataract surgery if there is a compromised capsulorhexis.
Thank you very much. I hope this has been worthwhile for you and for everybody. And I'm always there, because together we grow, learning from each other's mistakes, so that we are able to bring in better patient outcomes. Thank you again, Dr. Ishtiaq.
Thank you.